So I think we'll get started with an introduction while people are still filtering into the room. It's my pleasure to introduce my friend and colleague Josh Lang as today's Grand Round speaker. Josh is an assistant professor of medicine in the Hem-Onc division at the University of Wisconsin Carbone Cancer Center. Josh got his Bachelor's of Science at Iowa City at University of Iowa. He got his MD at University of Illinois at Chicago. And then he moved to Madison to do his internship and residency in oncology. And then when he was finished with that, he did a hybrid fellowship where he had heavy emphasis on research and was supported by the T32 training grant at University of Wisconsin. He started on the faculty as an instructor, I believe, and then joined the faculty as an assistant professor in 2012. And so he hasn't been independent very long, but he's become a very well-funded principal investigator. He collaborates extensively with David Beebe, who's an engineer at the University of Wisconsin, and Josh and David have been developing novel CTC capture platforms for interrogation of circulating tumor cells from patients with cancer. And Josh focuses primarily on prostate cancer, but I think he'll tell us a little bit about his work in other cancers as well. And I think he's even funded to do studies in lung and breast now too. So he's really branching out, really successful young investigator. I'm happy to have him here. Thanks, Josh.
Doc, is this going to help me? It's the most common question that I'm asked in my clinical practice, and it's the one for which I have the fewest answers. What I'm going to show you today are some of the technologies that we've been developing. These are my relevant conflict of interest, my relevant disclosures, and the technologies we've been developing to help us start to get at this answer and get more appropriate answers for our patients as they face these common clinical situations. The outline for today's discussion will go from the clinical context in which I feel these biomarkers could be relevant, how we implement these biomarkers in clinical practice, how circulating tumor cells may play a role in this process, and the engineering tools we've been developing for these purposes. And then I'll spend the second half of the discussion on our translational research studies, which is frankly where I'm having the most fun these days. Now, I like to start all of my talks with a clinical context. So this is one of my patients. He's a young man with known metastatic castrate-resistant prostate cancer. He's had 3 lines of prior treatment: hormone therapy, docetaxel chemotherapy, and abiraterone, a second-generation hormonal targeting agent. At the time of this clinical encounter, his symptoms are worsening from his disease, new back pain. So we face a decision. We have 3 available FDA Approved treatment options: Sipuleucel-T immunotherapy, enzalutamide, another AR-targeted therapy, and cabazitaxel, a second-generation taxane chemotherapy. Now, this situation isn't unique to prostate cancer. This occurs in all disease stages and all disease types, really in every cancer center across the country. What are we faced with in this clinical encounter? Well, it's when we reach these disease state transitions that the clinicians, our patients, we're faced with this challenge of how do we make that next decision? What's going to be most beneficial at that time? So what's the solution? Well, this is what I went to medical school for. Really, I break it down into 3 main processes. The first is we need to know the disease. What's the disease that our patient faces? What do we know about our patient? What biomarkers, what clinical information, what's happening with them? And then last, what do we know about the available therapies? And then we merge these 3 disparate pieces of information together and come up with a clinical decision in conjunction with our patient. All right, so he has known metastatic castrate-resistant prostate cancer. What do we know about prostate cancer? Very simply, prostate cancer is a disease that's often driven by the androgen receptor. A cytoplasmic transcription factor translocates the nucleus once it's bound its ligand, at which time it can activate a transcriptional program that's critical in driving the disease. We have many therapies currently approved by the FDA to target this AR signaling pathway, and resistance often develops, again, through the AR, whether we're talking about mutations in the androgen receptor, if we're looking at altered cofactor binding, if we're looking at splice variants, for example. All right, so there's what we know about our disease. What do we know about our patient? Well, he has known metastatic prostate cancer. He was diagnosed 10 years ago, a Gleason 4+5 adenocarcinoma, a poor prognostic sign. He has a rising PSA. His PSA has gone from 330 to 429 at the time of this clinical encounter. What do we know about his disease? Where is it? Well, we get standard scans. CT scan of the abdomen and pelvis shows liver metastases as well as lymph node metastases. Nuclear medicine bone scan shows clear evidence for why he's having new symptoms from his disease. He has widespread metastatic disease throughout the spine, throughout the pelvis. All right, so there's our patient. What do we know about the available treatment options? Well, we have Sipuleucel-T, an immune-based therapy that's shown to improve median survival by about 4 months over placebo. It's given as a single course, costs about $93,000 for that course. All right, what else do we have? We have enzalutamide, an AR targeting agent shown to improve survival in this clinical context by about 4 months. About 50% of men will get a benefit. Duration of response is about 8 months. It costs around $9,000 per month. Chemotherapy, cabazitaxel, about a 40% response rate, around 4.5 month duration of benefit, around $8,000 per month. Okay, you know as much as I do. What do you want to give him? So it's this fundamental challenge that we face, that the available information doesn't give us answers in terms of how we decide the next best treatment option for our patient. So when I break down treatment, the basic biomarkers that are available, we have multiple categories of biomarkers. Whether we're talking about diagnostic biomarkers, what's the disease that's present? A prognostic biomarker. Is there a baseline characteristic that, regardless of the treatments that our patients receive, gives us a sense for what their ultimate clinical outcome will be? Predictive biomarkers. Well, if we have a drug that is supposed to hit a specific target, is that target actually present? Pharmacodynamic biomarkers. If we give a drug to hit a target, do we actually modulate that target over the course of therapy? Or discovery biomarkers. Can we understand more about the disease in this individual that, again, would help give us some guidance as far as our treatment options? So for me, what I'm most interested in are these 3 categories: predictive, pharmacodynamic, and discovery biomarkers. So that's where I'm most interested in. When we think about these available biomarkers, there's really almost an endless context of use as far as where we could apply them. Therapy-specific, disease-specific, you name it, there's incredible opportunities for these kinds of biomarkers. Well, how has it actually been successfully employed? Non-small cell lung cancer, a lethal disease, but they've made the greatest advances in terms of the development of these kinds of predictive and pharmacodynamic biomarkers. So this was a landmark study that was published in 2011 in Psytrance Med. It was really quite amazing what they did at that time. It changed clinical practice completely. So what they did in this study was they enrolled 37 patients who had known metastatic non-small cell lung cancer. What was important about this study is that everyone came on and got a biopsy at baseline. That biopsy was then sent for genomic evaluation for sensitivity to an EGFR-targeted therapy, such as erlotinib. That's not what was important. What was important was that when patients progressed on that therapy, they went back for another biopsy. That biopsy was then sent for similar histologic analysis as well as molecular characterization. What was fascinating in the very first round of what happened for patients on this study, 37 patients had a diagnosis of an adenocarcinoma. On development of resistance to erlotinib, 5 out of those 37 patients now had a small cell lung cancer that was identified. Why is that such a critical clinical situation? Well, the average tumor doubling rate of an adenocarcinoma of the lung is around 100 to 120 days. For small cell lung cancer, 10 days. An incredibly lethal disease that's treated in a very different fashion for these patients. So at the very first reading of this, here's an important aspect for clinical practice. We need to do repeat biopsies to understand the disease. All right, well, let's actually walk through one of these patients and really, I think, some critical information when we do more intensive molecular analysis. So what they did for this patient, came in, biopsy, adenocarcinoma with a genomic mutation that suggested sensitivity to erlotinib. Patient got the therapy, had a great disease response, and a prolonged period of benefit. On developing resistant disease, biopsy was performed that identified that small cell lung cancer.
She's testing it.
It works. So we have this small cell lung cancer. Very importantly, this is a completely different treatment option for this patient. No, not at all. Thank you.
You want to turn this off?
Got it. I did.
Oh, you had it off.
Yeah.
Gotcha.
So a very different therapeutic option was started. Chemotherapy plus radiation therapy. It's a platinum doublet chemotherapy with cisplatin and etoposide. Completely different from what you would have gotten otherwise. Had evidence of a disease response, but importantly, on the development of resistance, another biopsy was performed that identified that original adenocarcinoma. So the predominant histology in this patient's tumor had been switching. So she actually went on to get that erlotinib therapy again and experience another disease response. This was completely different. This was revolutionary in medical oncology. We never go back to drugs that failed us previously. But in this situation, we had cellular and molecular information that suggested this is going to be important for you. And what we found was that, yes, she actually did get a period of benefit disease response, though did ultimately develop recurrent disease. Actually, that small cell carcinoma reemerged. What this tells us, what this tells me, is that when we do these kinds of interrogations, we can find clinically actionable information. When we think about the different contexts of use, though, in which we might apply this information, if we can get tissue, what should we do with it? Well, we think about the therapeutic interventions that are available. It's really developing this idea of a context of use. Where do we want to apply this predictive or pharmacodynamic biomarker? So we're talking about chemotherapies, targeted therapies, immune therapies, hormone therapies, antibody-drug conjugates. Really, it's limited only by your imagination when you think about where we could institute these types of predictive and pharmacodynamic biomarkers. Well, what's actually happened in clinical practice, if we look back over the number of drugs that the FDA has approved over the last 4 years, actually 11 out of those 38 drugs have an associated biomarker. Whether we're looking at HER2/neu, BRAF alterations, ALK, more recently PD-L1 expression, what's the common theme that extends across all these biomarkers, all these new FDA-approved drugs? It's that they're all predictive biomarkers. So there is movement in the field saying that, yes, we should be interrogating the biology of our patient's disease, and that can inform our therapeutic options. So let's come back to our patient. What do you want to biopsy? We've got a liver met, we've got a lymph node met, we have bone mets. What do you think we should go for? Sometimes that's driven by what tests we can perform. You know, I really prefer the liver met or the lymph node met for soft tissue. I probably want to do genomic analysis, though which genomic analysis I should do for that patient is still up in the air. How often should we biopsy? If we choose a site to biopsy, when should we go for that again? These are some really fundamental challenges, and especially for our patients with prostate cancer, where the vast majority of men have bone-only metastases. That's a real critical clinical question, a real challenge that we face. So that's where in my postdoc I came back to this question about circulating tumor cells. Well, what are circulating tumor cells, or CTCs? It's this idea that either primary or metastatic cancer sites can disseminate cells into peripheral circulation. Sort of the idea, if you're going to set up a new metastatic lesion, it has to get there somehow. Often it's through hematogenous dissemination. So could we potentially access these rare tumor cells from a simple blood draw? Well, that's the hope. The fundamental challenge, though, is these are incredibly rare cells. We're generally talking about one tumor cell for every billion peripheral blood cells. Sort of an order of magnitude beyond that needle in a haystack. What are the challenges that we face when we start doing circulating tumor cell analysis? Well, especially as we move from the idea of looking at solid tumor biopsies, we're really entering more of the hematopathology realm. And really smart hematopathologists know just how hard this is. I pulled this figure from one of my medical school textbooks. This is what I learned about the immune system, what's in circulation. These are the cell types that we have to worry about in terms of distinguishing a tumor cell from non-tumor cell white blood cells. Now, if I thought that was hard in medical school, when we actually get to reality, it's much more like this, where we have incredible heterogeneity. Very different what we see in peripheral blood compared to a tumor biopsy. So there's significant challenges in terms of identifying a real tumor cell from different white blood cells that may or may not express a specific marker. Well, what's the research that suggests that CTCs may even be clinically relevant at all? Well, there was one study that was done using a FDA approved platform, the cell search platform that Scott said is available here in Minnesota. What they did was they used an antibody for EpCAM, capture epithelial cell adhesion molecule, so they only captured cells that were expressing that molecule. But there's different cells in circulation, monocytes, macrophages, where their job is to eat up foreign materials. So you have these cells that could interact with the beads that you're using, the antibodies you're using to capture cells. But they went ahead and captured cells using this EpCAM. Then they did staining. So they did fluorescent microscopy staining for an intact nuclei with DAPI. They used CD45 as their white blood cell marker, well, even though we know that CD45 is not expressed on all white blood cells. And then they looked at cytokeratin staining. So they have a positive confirmation of cytokeratin positive events that it's negative for CD45, and that's now the FDA approved definition of a circulating tumor cell. So when they applied that definition to a cohort of patients with metastatic prostate cancer, they found that for patients who had more than 5 circulating tumor cells per 7.5 mils of blood, 1 tube of blood, that there was a significantly poorer outcome compared to those patients who had less than 5 CTCs in 1 tube of blood. All right, so our patient had 6 CTCs in his blood. How does that help you decide among those 3 options we talked about? All right, so CTC enumeration tells us there's some relevant biology there, but it doesn't necessarily get us to that answer that we want. What are some of the other important factors we have to take into consideration when we look at CTC enumeration? Well, are we really looking at tumor cells? I brought that up just for a moment. I want to come back to it, because when we think about developing a specific, accurate assay for our patients, that's really critical. Again, pathologists know this because that's what they do. They create biopsy, they take biopsy material, they develop the assays, things that can be moved into a clinical grade assay. So when we think about misidentification of CTCs or what was missed, sort of this idea, well, we know that there's issues in terms of epithelial and mesenchymal transitions, cancer stem cells. Are these all cells that are in circulation? Could that have been missed with that cell search assay that only used EpCAM to capture? Well, it's a fundamental question, but why is it so important in this field when we think about accuracy? Well, it's because a study that was done looked at CTCs and found that 21% of the cells they captured were actually white blood cells. They had that EpCAM positive, CD45 negative definition, and they were wrong 20% of the time. As a clinician, I don't like to be wrong 20% of the time. So there's some very important issues, especially as we think about delving into this other issue in terms of EMT, cancer stem cells, you name it. These are some things we need to take into consideration. All right, so we've talked about CTC enumeration, we've talked about our scans, and fundamentally as a clinician, I'm using what's available, but that doesn't really help get at what I want to know. So what do I want to know for our patient? Well, I want to know what the androgen receptor is doing. Is it cytoplasmic? Is it nuclear driving transcription? Okay, I'd like to know that. I'd like to know are there variants? I'd like to know if there's activity in that AR pathway. Is the AR inner binding DNA, is it driving that transcriptional program or not? Because that could help inform me on what therapeutic we should be going for. So that's where we come back to what are the kinds of CTC biomarkers that I'd really like to have? Well, what I'd like to do is move beyond enumeration. I'd like to start getting into genomics, gene expression, proteomics, and then using that information to help us ask, who's going to respond to our therapies? Why does resistance develop? When does it develop? Especially if we can do these types of longitudinal analyses. We can get blood every month. Can it help tell us what the next therapy should be? And more importantly, can we use that information to do rational combination strategies? Can we target cancers in multiple different fashions at the same time? So I'm going to walk you through some of the work that we've been doing with our biomedical engineering colleagues. Scott mentioned Dave Beebe, who's a phenomenal collaborator at the University of Wisconsin. So what Dave was doing, he's doing microfluidics, and microscale engineering. And when I first met him, when I thought of microscale engineering, what I thought you did is you took a very complex device and you shrunk it down into a very small complex device. Dave was taking a very different approach. He was trying to leverage physics at the microscale. We've all seen a water bug sitting on top of water. How does it do that? Well, at the microscale, surface tension is a dominant force over gravity. So what Dave and his team were doing, we're taking different types of solutions, aqueous and immiscible solutions, such as oil or even air, and putting them in physical contact with each other. It's at that interface that it creates essentially a barrier that you can use to separate different analytes, or exclusion-based sample processing, as Dave likes to call it. So let me show you the videos in terms of what Dave was doing when I first met him. So this was the chip that he and his team had started with when I met him and really sparked my interest. So what you're going to see here in yellow is an elution buffer. Here's a wash buffer, and in red is a complex cell mixture with magnetic beads added to bind a cell population of interest. The clear liquid here is oil. So what Dave and his team were doing were then just applying a simple external magnetic force, and as we apply that, you'll see a bead aggregate form. Those are the beads that have bound our cells of interest. They approach that interface and are purified from the sample in which they started. We pull them through a wash buffer and into an elution buffer. And in 45 seconds, we've done a complex cell sorting experiment with our original sample still in place for reinterrogation. So we took that very simple process and literally turned it on its side. We moved it into a vertical orientation that allowed us more operational paths. So what we can do is we can take a blood sample from a patient, we can generate a buffy coat, put that buffy coat into the input well of this handheld chip. We can add magnetic beads with antibodies for whatever target we're interested in. let them sit for 30 minutes. Then we apply that external magnetic force and pull it across that oil barrier to essentially purify or enrich the cells that we've captured from the population in which we started. We can pull it into this next well where we add antibodies for extracellular staining for any protein target of interest. We let the cell sit for 30 minutes, then we apply that external magnetic force again, pull it through that next oil barrier, essentially removing any unbound antibody. It helps us to eliminate any centrifugation steps, any transfer steps, really that are so critical when we talk about rare cell analysis, because if you lose 10 or 20% of your cells in the centrifuge or in a transfer process, you killed your assay. Well, after we've done our extracellular staining, we pull them into the next well where we can do intracellular staining, and I'll walk you through how that's performed, but then we can do intracellular staining for any protein target of interest along with quantification. Now, after we've done our fluorescence microscopy, our cells are still sitting there. So what we can do is add a lysis buffer along with magnetic beads that have an oligo-DT attached to it to bind mRNA. We pull those through that front half of the device so we can purify mRNA, but our tumor nuclei are still retained. So we can apply that external magnetic force again to extract DNA. So we add a high salt lysis buffer along with silica beads, pull those beads through the back half of the device, and we can extract DNA from that same cell population. So here's actually how we do nucleic acid extraction in my lab. So here's one of the original chips in which we started. Here's the well in which we have our sample. We apply that external magnetic force. We pull those beads across that oil barrier and into the elution buffer. We then add our high salt lysis buffer along with our silica beads. And admittedly, I took out the 5-minute incubation step from the video, but then we apply that external magnetic force again. We see the bead aggregate form. We pull it across the oil barrier and into the elution buffer. So a simple process in which we can do total nucleic acid extraction. So let's walk through some of the metrics. How does the device actually perform? So we did a few series of experiments. We took this chip, we took white blood cells from our patients, we spiked in 500 LINCAP tumor cells into 5 million white blood cells, about the equivalent of a 10 ml 2-week blood. We added our antibodies for capture, and we found that whether we had 5 million, 20 million, or 100 million background or contaminating leukocytes, that we could capture approximately 95% of the tumor cells with which we started. We then asked, well, how well does that purify? Because we're trying to enrich and get a pure population for downstream molecular characterization. We found that we were able to reduce 5 million tumor cells down to about 100 to 150 with this process, just that one pull. If we used multiple wash steps, we found that we really didn't improve purity. We didn't really lose much either, suggesting that we can move cells through the chip. Once we've captured them, we've got them. We're not going to lose them along the way. We then, in this experiment, took one tumor cell and put it into 20 million white blood cells, and we got it. We actually call that the cell. So we have single cell resolution for some of our downstream molecular analysis. We've integrated our cell staining, as I had mentioned before, into that first well. And these are circulating tumor cells from one of my patients with prostate cancer. With EpCAM in red, the nuclei in blue, and then white blood cells are stained for CD45 in this experiment in green. So we can do high resolution fluorescent microscopy with the cells that we're capturing. Well, we next want to say, well, again, we can now count cells, so we can do what others can do, but that's, again, not what we wanted. We want to do intracellular analysis. So there was a phenomenal graduate student at the time named Ben Cassavant who took that next well of the device and manufactured in an 8-micron pore membrane. Well, what happens in that well then? With that membrane, it creates a front and a rear well. So we capture our cells, we pull them across that oil barrier into the front half of the device, into that front half of the well. But we can do fluid exchanges in the rear half of the well. Well, what does that allow us to do? Well, we've got our cells, we've captured them, we can do fluid exchanges to do permeabilization of our cells. Primary antibodies and washes, secondary antibodies and washes, all on the same chip without any transfer, without any centrifugation. It allows us to do intracellular analysis for proteins like the androgen receptor. So this is a circulating tumor cell where we've defined our nuclear region here, our cytoplasmic region here, and then we overlay that mask on top of our androgen receptor stain. That allows us to do a quantification of the nuclear localization of our protein of interest, in this case, the androgen receptor. Now, I mentioned before, yes, we can do nucleic acid extraction for both RNA and DNA after we've done our fluorescent microscopy. How well does that perform? Well, we did a series of cell dilutions, 1, 10, 100, and 1,000 cells, compared that to standard QIAGEN kits that were available. and found that yes, we could get single cell resolution when we do gene expression analysis, and had even better resolution when we looked at DNA, when we compared these different kits. Suggesting that yes, we do get nucleic acids for both RNA and DNA extraction, and we can get single cell resolution. So if we capture it, we can do those downstream molecular analyses that we're most interested in for our patients. So now we're going to switch. So we're going to move, we've talked about clinical context, we've talked about the engineering tools that we've been developing. What are some of the areas in which we've applied these different technologies? Well, again, I keep coming back to the androgen receptor. Scott's in the front row, so I know I've got to do that. We want to start asking some of these molecular characterizations of the androgen receptor in our patients with prostate cancer. So we first started off by taking a cohort of patients with known metastatic castrate-resistant prostate cancer. We did intracellular analysis, and on this axis, what you see is the percent of the androgen receptor that was localized to the nucleus. Our first cohort of patients had had no prior therapy. They were castrate-resistant, but hadn't started their next line treatment. And what we found when we looked at nuclear localization of the androgen receptor was actually incredible heterogeneity. We had cells within the same patient with as little as 10 up to 90% of the AR localized to the nucleus. So really dramatic heterogeneity. In patients who had started AR-targeted therapy, such as abiraterone or enzalutamide, that heterogeneity shrunk. We saw less of the AR localized to the nucleus, and similarly with docetaxel chemotherapy, again, relatively little AR in the nucleus, but also, again, that heterogeneity had shrunk. But it was in those patients where disease had developed resistance that's where that heterogeneity reemerged. We had broad range with cells with, again, as little as 10, but now cells for the first time with 100% of the AR localized to the nucleus, suggesting that when we think about the treatments that these patients are getting as they progress on enzalutamide, here's a subpopulation of cells that have that clear phenotype that we would suggest would be AR independent, not AR independent, but resistant to our AR targeted therapies. Well, so now we can do some protein information. We can start to get some studies, and that's actually moved on to clinical trials that I'll discuss in a moment. What about other relevant targets that we want to analyze? There's been interesting data suggesting that expression of the V7 splice variant of the androgen receptor correlates with resistance to these AR-targeted therapies. Actually predicts resistance in this study coming out of Johns Hopkins, where they found that patients who did not have benefit from enzalutamide, the vast majority of them had detectable expression of this androgen receptor V7 splice variant. So we asked the question, can we start to do these types of gene expression analysis, looking for the presence of these AR variants? But we wanted to add more onto that. Because again, what do I want to know? I want to know if the AR is driving transcription in this disease. So we did a cohort of patients. These were 26 patients at the University of Wisconsin who had diagnosis of castrate-resistant prostate cancer and were receiving second-line hormonal therapy, either abiraterone or enzalutamide. All these patients came in, they donated blood, and we looked at their PSA. So for men who had PSA progression, knowing all the limitations with PSA, men who had at least 2 consecutive rises in their PSA that would suggest development of resistance to their AR therapy, well, we then sent those men on for radiographic imaging. What we found was that there's a subset of men who, despite PSA progression, there was no radiographic progression, again, as we'd expect. But there was a subset of men who did have radiographic progression on CAT scan and bone scan. So we did gene expression analysis for the androgen receptor, the full length and total AR, multiple AR variants such as B1 and B7 and 567ES, as well as those downstream targets, TMPRSS2, PSA, PAP, PSMA. We look for expression of those downstream targets, and if that could give us some information if the AR was driving transcription. What we found were that the presence of multiple variants were correlated, or they were predictive of resistance to that AR-targeted therapy. Interestingly, though, it was only in a subset of patients where we found that TMPRSS2 expression as well as PSMA also correlated with disease resistance, radiographic progression. So this idea that, yes, there are a subset of patients where the AR continues to drive disease. Now, importantly, PSA, PAP expression, that was detectable regardless of what the CTCs were showing, regardless of what the disease status was, regardless of what serum PSA was. Not necessarily a surprise, but it gives us some information in terms of, well, the AR for this subset of patients can still drive disease progression. Well, I want to walk you through one of my patients who, because again, that was just a baseline characterization, we want to be able to do this longitudinal analysis. We can collect blood every month from these patients. We don't have to do these biopsies. Well, what kind of information can we get that might inform us on the status of their disease? So this is one of my patients, a 62-year-old gentleman, presented first diagnosis with metastatic prostate cancer. His PSA was 35.7. He had lymph node metastases as well as bone metastases. We collected blood when he started to get treated with chemohormonal therapy, so combined androgen blockade with bicalutamide and leuprolide, and also docetaxel chemotherapy. He had an amazing response. So after 3 cycles of chemotherapy, his PSA went down to 0.07. He had an almost complete radiographic response as well. So we said, let's keep going. So let's collect blood. This was at cycle 4 of docetaxel chemotherapy, and we found, let me walk you through what we see here. So in this axis here, each dot is a single cell. This is AR nuclear localization on this axis, and on this axis is AR expression. And then here's the gene expression panel that I showed you in the last slide, looking at AR variants as well as multiple targets in that AR pathway. What we found was that at cycle 4 of docetaxel chemotherapy, only 6 CTCs, whether that's a bad prognostic sign or not, we'll learn. But he had 6 CTCs, and a couple of them had high nuclear localization, but really very few cells, and almost no activity in his AR signaling pathway. We went on for cycle 4 of chemotherapy. He comes back in a month later for cycle 5. Concerningly, at cycle 5 of chemotherapy, his PSA started to creep up from 0.07 to 0.42. Now, he's asymptomatic, so we're going to continue with the therapy, but that's a very poor prognostic sign when the PSA starts to rise on chemotherapy. When we looked at his circulating tumor cells, it had exploded. He had dozens of circulating tumor cells, many with AR overexpression as well as high nuclear localization. And we're starting to see a little more activity in his AR pathway as well as being able to identify ARV7 as present. Now, he's still asymptomatic, so we said, we're not going to change your therapy based on a PSA that's just gone up a little bit. Let's go on with our next cycle of chemotherapy. Come back in and let's see where the disease is at. He comes back in. His PSA has gone up to 1.19, but still asymptomatic. We still have high burden of circulating tumor cells, but now we're starting to see even more activity in his AR pathway. Well, he's had 6 cycles of chemotherapy. He needs a break, but I'm concerned that his PSA is rising. So I said, let's have you come back in a month. Take a month off, come back and see where things are at. He comes back in a month, and his PSA has shot up to 41.7. He's had a phenotypic shift in his circulating tumor cells. Not so much of that nuclear localization, though some of those cells are present, but more of an AR overexpression signature. He now has presence of that ARV1 variant and even more activity in his AR pathway. The androgen receptor is still driving his disease, but we now have clear resistance signatures. He was going to go on a clinical trial. We had to stop the bicalutamide before we could start that trial, so we said, come back in a month because you're still otherwise feeling good so we can get started on this next therapy. His PSA continued to rise, and for the first time we detected the AR567ES variant as well. So a very disordered genome, as Scott might hypothesize, multiple variants, and even more activity in his AR pathway. So what we think is that we're getting some interesting and important cellular information, some biologic information for our patients when we do these longitudinal analysis with circulating tumor cells. I mentioned before that we can also extract DNA. Well, DNA is one of the most challenging things that we do because DNA requires a high purity of sample, generally at least 50 tumor cells at least 50% purity. It's the most challenging thing for us to do. But when patients have that high burden of disease, that allows us many opportunities. This was one of my patients who had known metastatic prostate cancer with liver metastases on his CAT scan, extensive bone metastases as well. We did the same type of integrated molecular analysis from a blood draw. We found that he had around 20 circulating tumor cells, some with high nuclear localization after he progressed on abiraterone. Multiple AR variants were present, as well as high activity in his AR pathway. On genomic analysis, 8q gain, AR amplification, as well as a p53 mutation. So we can start to integrate these disparate types of molecular information to understand our patient's disease when we do this type of intensive molecular analysis of circulating tumor cells, not just enumeration. We've been able to advance these biomarkers into prospective clinical trials. That's the next question. Well, I'm showing you some information that I think may be relevant. Is it actually? That's where we need to do prospective clinical trials. These biomarkers need to be integrated into different studies. We have 4 ongoing multi-site phase 2 clinical trials where my lab is the central processing site with enzalutamide, abiraterone, BT464, a new lyase inhibitor that's been developed, We've integrated another clinical trial where we're doing molecular imaging along with enzalutamide. So we can look at these and try to ask and answer some of these questions of, can we identify signatures of resistance, intrinsic resistance to the disease before people start the therapy? The development of early resistance and acquired resistance, again, as patients are treated. So this is some of the clinical studies that are ongoing now, and I expect we'll have completion of those studies in the course of the next 1 to 2 years. Well, what else can we do? So we talked about some of the directions where we can take this. Well, we're also doing a number of translational research studies to try to interrogate and understand the biology of our disease, of our patient's disease better. So we did another study asking, well, what about heterogeneity? There's a lot of discussion, and I mentioned it before, about what about EMT or cancer stem cells? What might be happening with these different types of putative cells in circulation if we can do these highly specific analyses? So we wanted to start asking these questions of, can we start to identify cells that are either EpCAM positive, sort of an epithelial cell, as I showed you in all that data before, with EpCAM-based capture? Can we start to look at these mesenchymal cells where they express proteins such as vimentin or any of the cadherins that might be involved with mesenchymal transitions? Does that really exist in our patients? So we did a study where we took blood draws from our patients. We had wonderful patients, donated 50 mLs of blood. We split them into 3 different chips, where we did EpCAM-based capture, N-cadherin as a capture methodology, as well as CD133, a putative stem cell marker. We went through that same process that I showed you before, and what you see on this axis is our first attempts at identification. So we have cytokeratin expression on this axis, and on this axis, we're looking at what we call a dump channel. So we're staining for multiple markers, because we're branching out into a very different field. So we did staining for CD45, CD11b for neutrophils and monocytes. We also stained for CD34 for an endothelial cell marker. We're in the bloodstream. These are cells that are going to be in circulation that are large nuclear structures that certainly could be confused for circulating tumor cells. So what we do is we exclude any cells that are high expressors sort of this dump channel. What we found were that there were 61, 74, and 31 putative circulating tumor cells, whether we use EpCAM, N-cadherin, or CD133. So we're identifying some heterogeneity. Are they real tumor cells? Well, then we did androgen receptor analysis. So what we looked at were just expression intensity of the androgen receptor, comparing across white blood cell subsets and CTCs. When we look at the mean fluorescence intensity on this axis, we find that it's generally quite low in most of the cells that we are finding with this dump channel. About 2 to 3-fold, even 4-fold higher for some of these cells when we use EpCAM-based capture. Similarly, when we use N-cadherin or CD133, we can identify some putative cells that express the androgen receptor. So there may be, and we think we're finding some heterogeneity in this populations of circulating tumor cells in some of our patients with metastatic prostate cancer. So we have some interesting phenotypic information. Well, can we get some more molecular information to understand, well, what cell types might be driving disease resistance? So we did that same gene expression analysis because we have that capacity with the chips. So here's one of our patients who was treated with abiraterone acetate at the time of this blood collection. His PSA had fallen over the course of 3 months of therapy. He'd gone from 300 down to 80.83. We looked at gene expression and found that at this time point, we found total and full-length AR in his EpCAM captured CTCs, as well as expression of TMPRSS2, PSA, and PAP. So a similar profile that we might expect. What's interesting was that when we looked at N-cadherin or CD133, we didn't see that signature. So we didn't see that expression of the androgen receptor. All right, so an interesting idea. He came back in a month later. His disease exploded on abiraterone. He very rapidly developed resistance, and his PSA went from 80 to 408. This is actually the patient where you'd want to look for mesenchymal signatures or for stem cells. What we found when we did EpCAM, CD133, or N-cadherin capture, that while we start to see more AR expression in these cell types, we only saw AR variants in his EpCAM fraction. So only the epithelial cells had that treatment-resistant signature. Now, does that mean these other cell populations don't have invasive or metastatic potential? I don't know the answer to that. Those are some of the other questions that we want to start to delve into. But we didn't see that same treatment-resistant signature, or at least the AR wasn't driving those cells. What was important is that the scientists in my lab then said, well, I want to do a follow-on experiment. We pulled out within our chips, those CD133 or those N-cadherin cells. But our well is still there, our sample is still there. I'm going to add some EpCAM beads and see, well, what can I capture? Was it just a flaw in the assay? Do we have some error? What she did EpCAM-based capture after CD133 or N-cadherin, all those cells were there. All those EpCAM positive cells that were captured had those AR variants, high activity in the AR pathway. So what it suggests is that at least when we look at treatment resistance for this patient, it's really in that epithelial compartment that we need to be looking. And now we can start to ask some of these other questions as far as what's relevant in terms of disease resistance, heterogeneity, disease progression in our patients with these types of analyses. Well, what about other diseases? The androgen receptor is not only expressed in prostate cancer, though that's often where we think about it. I have a collaborator in breast cancer who said there's some data in triple-negative breast cancer. Can we do these types of studies? We actually have a Big Ten study that's going to be opening with palbociclib and bicalutamide, and we're going to be doing these AR analyses for patients with triple-negative breast cancer. Another colleague said, what about non-small cell lung cancer? There's actually some data that suggests that the AR is expressed in non-small cell lung cancer. Can we apply these same types of analyses in that context? Well, we said, sure, let's look at it. What do we think? How could the AR be driving disease progression in non-small cell lung cancer? I initially thought, well, we're really going to be thinking about the same process that occurs in prostate. The AR is going to translocate to the nucleus, and we can identify it there and see if it's impacting transcription. What was important, though, is that there's a whole other host of data suggesting that the AR can have sort of a non-genomic impact on disease progression, that the AR can interact with Stark kinase, heterodimerize with EGFR, and that itself can drive transcription. EGFR is far more relevant in lung cancer. So is that an alternative pathway in which doing subcellular localization of the AR actually won't be important, wouldn't be relevant for these patients? So we first started by asking, can we detect the androgen receptor? So we did some cell line staining looking at LNCaps of prostate cell line, A549 is a lung cancer cell line, and a lymphoblastoid cell line, and found that yes, we can detect weak signatures of the androgen receptor in these cell lines, so we can optimize and develop our assays for these types of purposes. When we look at AR staining intensity, yeah, it's certainly higher in LNCaps as we'd expect, but it is detectable in these A549s. We asked, can we actually detect mRNA at the transcript level for those gene expression studies that I showed you before? Looking at cell lines, yes, we can detect full-length AR in LNCaps at very low levels in A549s. We don't detect them in our white blood cell line, though we do detect CD45, again, as we'd expect. So we can start to connect these dots in lung cancer. So let's start testing them in patient samples. I was surprised and interested that we actually did find expression of the androgen receptor in non-small cell lung cancer. We do see staining intensity for the androgen receptor, cytokeratins, no expression for these other white blood cell and endothelial markers. And now we can start to do that quantification. Is the AR localized to the nucleus or not in these cells? So we took 4 patients with metastatic non-small cell and found that there was a range of circulating tumor cells from 5 all the way up to about 90 for this patient. When we look at the frequency of cells that actually have detectable AR expression, actually it's between 60 to 90% of the cells did have detectable AR expression. When we look at nuclear localization, though, the majority of these cells actually don't have AR in the nucleus. It's mainly cytoplasmic for the vast majority of these events. When we look at gene expression analysis, we found that there is a loose correlation of AR expression in patients who are progressing on their on their targeted therapies with metastatic non-small cell. So it's hypothesis generating. I don't know if it's relevant in the disease process. These are the questions that we want to ask and start to ask, can we intervene with different therapeutic agents? But now we can start to do these sort of exploratory biomarkers that we would not have otherwise performed. Well, let's come back to our patient. He has an AR-resistant disease. We're looking at different treatment options we might consider for him. Is AR the only pathway that we should target? We started asking some questions of, can we do alternative targeting for our patients? There's different drugs that are out there. There's a lot of excitement about immune therapies in multiple different malignancies. When we look at prostate cancer as far as FDA approved therapies, we're talking about Cipralex-T, a sort of a complex vaccination strategy against prostatic acid phosphatase. We look at checkpoint inhibition in melanoma, non-small cell lung cancer, as well as renal cancer, that's shown clinically relevant, clinical improvements in terms of patient outcomes. Well, let's step back. What kind of biomarkers do I want to have? Because right now we're limited to PD-L1 expression, and as I think everyone in this audience knows, PD-L1 expression in tumor biopsies is exceptionally challenging to perform. The reagents are challenging to work with. So what information do I want to know? Again, not what do we have, but what do I want to know? Well, when we think about how an immunotherapy might have an anti-cancer impact, well, if we're relying on a CD8 T cell response, we're relying on a T cell that can recognize a specific antigen in the context of MHC class 1. All right, so those are two things I want to know. I want to know what antigens are being expressed. I want to know, are there competent MHC class 1 complexes on the cell surface? Because if those aren't there, your checkpoint inhibitor certainly won't. Well, that's the other part. Well, I'd also like to know about the expression of those checkpoint inhibitors, or molecules. Is PD-L1 being expressed, or PD-L2 expressed on the cell surface? So those are a few questions that we'd like to have answers to, or at least I would. So we first started asking, okay, this is important. We think this is important. There's preclinical data. Conceptually, it makes sense. Well, what's actually happening in patients? So we first started doing multicolor flow cytometry, and we looked at MHC class 1 expression in cell lines. Here's our unstained cell line. Here's RWPE1s and prostate epithelial cell line. And here we have LAPC4s, LNCAPs, 22Rv1s. And we find that there's an incredible range, a heterogeneity in terms of competent MHC class 1 expression in cell lines. All right, so we certainly have heterogeneity, and we can start to do this analysis. Now, this might be relevant in prostate cancer. So what we did is we then took a prostate biopsies from patients with known prostate cancer, and we did dissociation of that tumor mass and did multicolor flow cytometry. So we looked for cells that were cytokeratin positive and positive also for the androgen receptor. So we took those epithelial cells, and then we looked on this axis in this dot plot for HLA, so MHC class 1 expression, as well as PD-L1 expression. We looked at normal and tumor tissue, all from the same prostate biopsy. We found that in the histologically normal tissue biopsy, we found that there was generally fairly high expression of MHC class 1 molecules and some low-level expression of PD-L1, really, I think, as we'd hypothesize in any normal tissue. However, in the prostate tissue, we found that that percentage of cells that were expressing MHC class 1 dropped down to 3.7% of the events. The number of events that were positive for PD-L1 but also negative for class 1, sort of that immunotherapy-resistant population, more than double. So we think that when we look at normal versus tumor tissue, that yes, actually expression of class 1 molecules in PD-L1 is relevant in prostate cancer and could potentially predict resistance to these immunotherapies for our patients. So then we started working to ask, can we identify these populations of cells in circulation? And it's where you really have to come back to your assay development. And I think that's one of the things that's just so critical, and pathologists get this really better than anybody else does. So we wanted to look for EpCAM captured events, looking at low CD45 but cytokeratin positive events, knowing, however, that CD45 can be low on different white blood cells, such as neutrophils and myeloid-derived suppressor cells. We did cytokeratin staining because when we first looked at some microscopy, we found that, hey, look, we have these events that are both positive for cytokeratins and CD45. That really shouldn't be, right? Well, it turns out those are often positive for CD11b. So we said, let's come back to actually multicolor flow so we can try to understand this population of cells a little bit better. What we found were that when we look at CD45 low but CD11b positive cells, we could get positive staining for cytokeratins. Well, I'm trying to develop a specific biomarker for PD-L1, which we know is expressed on neutrophils and other white blood cell subsets. I want to look at tumor cells that may also express PD-L1, but now I have events that are cytokeratin positive. All right, so that just killed the assay right there. Fortunately, I have postdocs who are smarter than I am. They said, let's come back and understand this a little bit better. And when we use isotype controls, we find that it's actually autofluorescence. Again, not surprising in neutrophils, which have complex cellular structures, complex granular structures. They autofluoresce. There will be non-specific interaction with our antibodies. So what we tried to do was develop a more specific assay, integrating CD11b to identify these non-tumor cells that would be PD-L1 positive. So what we found when we did that, where we captured circulating tumor cells, we looked at expression of PD-L1, and for a subset of patients, it made no difference whether we used CD11b or not. But there was a clear subset of patients that when we added CD11b, that the fluorescence intensity, the expression on actual tumor cells, dropped to almost negligible levels. So rather than a PD-L1 positive event, this was a PD-L1 negative event. Now, why is this important to me? And this paper is under review right now. Because Scott and I just got back from AACR, where I saw no less than 3 posters talking about how many of these PD-L1 positive CTCs are everywhere. It's amazing when you do a blood draw just how many of these cells are there. Like, exactly, because they're white blood cells. Not everyone responded positively to that comment. I put it a little more gently than that, but the short of it is that we really need to take into consideration heterogeneity in blood. But when we do that, we can find that, yes, there are a subset of patients that have very high expression of PD-L1 on circulating tumor cells. The majority do not. When we look at PD-L1 just positive or negative and we set different thresholds, we find that there is significant heterogeneity. And that when we think about potential benefit from immune-based therapies, well, here's some subpopulations of cells that clearly may benefit, subpopulations of patients who may benefit. We need to do this in prospective clinical trials to ask, do we see this as a predictive biomarker or not? So those are some of the specific assays we're trying to advance when we look at PD-L1 expression. I've got a few extra minutes, so I'm going to take a little bit of time just to take a little detour, and I promise I'm going to come right back. Because the other thing that comes back to me in prostate cancer, well, if I have cells that are low expressors of class 1 that may or may not express PD-L1, do I have any available immunotherapies that would help that patient? Unfortunately not. When we look at the available ones, they all require that competent class 1 complex. So unfortunately, the available treatment options, we don't really have those. We don't have anything right now. So we started coming back in the lab asking a question, well, could we start to use these biomarkers, use this biologic information to help us with therapeutic development? So is there anything out there that actually might induce class 1 expression? So that's where we started thinking again, coming back to pharmacodynamic biomarkers. Can we identify a novel therapy, something that would be in a phase 1 developmental context or phase 2, that we could ask some of these other translational questions? There's actually a lot of information about epigenetic targeting therapies. So if we pull up the UCSC genome browser, what we can find when we look at HLA or beta-2 microglobulin, again, the components of that class 1 complex, that there's actually massive CpG islands. And when we do genomic analysis, it's not that these tumor cells have lost the HLA or beta-2 microglobulin complex, but it's not being expressed. And there's some data suggesting that it actually may be regulated at the epigenetic level. So we have actually available hypomethylating agents. We have HDAC inhibitors, drugs that have not worked very well in prostate cancer if we think about resensitizing them to AR or chemotherapies. Could this be an alternative strategy where we could use these types of epigenetic modifying agents for these types of, to induce class 1 expression for immunotherapies? So we came back to some cell lines. We took multiple cell lines. This paper is under review right now, and we did treatments with either a vehicle, LBH589 at different concentrations, which is an HDAC inhibitor, or hypomethylating agents such as 5-ASA, or the combination of both. And we found that when we look at class 1 expression, as well as neoantigen expression, these are cancer testis antigens on this slide, what we found were that there's very little baseline expression, but they can be highly induced when we use these epigenetic modifying agents. So we can actually potentially induce not just class 1 expression, but also neoantigens with these types of drugs in prostate cancer. Well, is that actually relevant for patient samples? You know, we all know the limitations of in vitro models. And I went to NCI and said, we've got some great preclinical data, what do you think? And they said, well, that's really nice preclinical data, but is it actually occurring in patient samples? What's your translational context, and why should we use these expensive and sometimes toxic drugs? So we came back and tried to develop a new model to help us ask in a patient-friendly context if this might be relevant. So we developed an ex vivo prostate tissue assay. So one of our collaborators in urology was giving us prostatectomy specimens. We dissected out, our pathologist said, here's a region of normal prostate epithelium as well as tumor. We took those two distinct regions, we did vibratome sectioning, and then cultured these tissue slices on an absorbent sponge matrix. We can then do different infusions, so we can remove that media, we can put different drug treatments on that tissue culture, and start to ask, well, in human tissue, can we see relevant alterations? We did some of these studies looking first at H&E stains. If we're going to culture these tissue slices in the presence of drugs, they have to remain viable for a period of time. We found as we go from 0 to 6 days that the normal prostate epithelium is intact, though we do see some histologic alterations. Similarly, in that tumor core, we see that it is surviving out to 6 days. So we think that we can do some of these types of drug treatments and get some potentially important information. So we looked at different components of the antigen presentation machinery complex, class 1 expression. And we found that when we use this ex vivo drug culture, that there's a subset of patients when these samples are treated with HLA or with azacitidine that we can induce expression of competent MHC class 1 complexes. Not in everybody, but in a subset of patients we can induce expression. We looked at some of these neoantigens, these cancer testis antigens, and we found that we can induce neoantigens in 8 out of the 9 patients that were treated, or whose samples were treated with these different drugs. So we think we might have looked at or identified some potential translational context, new agents that could synergize with our immune-based therapies. Well, do we have biomarkers for that? Well, let's come back to circulating tumor cells. If I'm going to give a drug, we want to collect blood in conjunction with that. When we looked at class 1 expression, here were 2 different patients as we look at class 1 expression. With one patient in their circulating tumor cells, complete absence of a competent MHC class 1 complex, especially as we compare that to white blood cells from that sample. Another patient with broad heterogeneity, especially even higher expression when we compare that to white blood cells. So a potential biomarker that we can integrate now for epigenetic modifying agents in this immunotherapy context. We can also do gene expression analysis and identify neoantigens such as SSX2, one of those cancer testis antigens, as well as other putative targets such as PAP or PSMA that have also been proposed in different vaccine-based therapies. So to wrap up, when we're trying to develop translational biomarkers, there's multiple critical levels that we need to consider to develop a biomarker for clinical use. We have to know our disease. We have to know our therapy. When we have that information, we can then develop the context of use for that biomarker. Now we've developed that context, next we have to go into the very critical steps of analytic and clinical validation of that biomarker. And with that information, now we can move on to prospective clinical trials to ask, are these predictive and pharmacodynamic biomarkers that could be relevant for patient care? Before we end, I want to come back to our patient that we started with. His PSA rose to 429. I didn't have any available biomarkers, so we made what we often do in oncology. We made a toxicity-based decision. So you're having symptoms from your disease. Enzalutamide is a drug with very few side effects. We'll go with enzalutamide instead of chemotherapy. We collected blood. His CTCs had cells that had 100% of the AR in the nucleus despite the abiraterone that he'd been previously receiving. Unfortunately, he had no benefit. His disease progressed rapidly within less than a month, and he was on hospice 3 months later. So that decision that we made, the information we had, wasn't sufficient. It didn't give us the guidance that we needed to help our patient in this context. So could he have benefited from a predictive or pharmacodynamic biomarker? I think so. And these are the patients that we think we can help as we move forward with these different classes of biomarkers. With that, I'd like to thank you for your time and attention. I'd like to thank the many people who have been involved with this project. Our funding sources, the Prostate Cancer Foundation, Movember as well. Please be kind to Scott when he grows a mustache in November. Aaron as well. The many members of my laboratory who have been instrumental. We have our clinical trials group who are processing our clinical samples, Haley and Anu, as well as our oncology fellows, Dave Kossoff and Wada Arafat, our scientists in the lab, Erica Henninger, as well as James Berger, postdocs, Josh Desatel, and Jennifer Scher, as well as our many undergrads. Our clinical research group, we can't do this without our clinical research colleagues, our clinical researchers who identify patients, consent them, help us get our blood samples to us every month, as well as our collaborators in biomedical engineering. Most importantly, I want to thank our patients and their families. They donate blood. We've consented over 350 patients at the Carbone Cancer Center who are donating blood on a regular basis. They say, this is not for me, this is to help somebody else in the future. Take it, I'm really not using it, and hope you can find some important information. Thank you for your time and attention. I'm happy to take any questions. In the back, please.
Yeah, really awesome technology. I just have some questions about the analytical performance of your test. So have you done some, I'm just curious, how often do you detect circulating epithelial cell malformations, patients with prostatitis, for patients with localized prostate cancer, and then for those with known metastatic cancer? It seems like it's a really awesome technology, but only a subset of your patient populations can themselves.
It's a perfect question. So the first in terms of the analytic validation. So the performance characteristics are a little bit different from the second half of the question that you asked. So in terms of the performance characteristics, we validate all of our reagents every week. So we test to say that yes, when we do capture experiments, we prepare reagents, that we're still capturing 95% of the cells that we start with, and those reagents are validated. To start asking, is this assay going to be useful? Can we test it in these different clinical contexts that you described? So now when we start asking in these other clinical contexts, and it's really, you asked again a perfect question, because there's data out there suggesting, I know one company that's saying we find these circulating tumor cells, as they call them, in patients with localized prostate cancer. Hundreds of events, which blows my mind. Because clinically, if there are tumor cells, they're not relevant, they're not clinically significant. I'm very worried about specificity with those assays. So we've taken on a study with Ken Pienta at Johns Hopkins for patients undergoing prostatectomy, where he's collecting bone marrow aspirates as well as matched blood for these studies, looking for disseminated tumor cell signatures. I can tell you that we find putative circulating tumor cell signatures with either the protein stain or with the gene expression analysis in less than 10% of the samples we tested. Now, that's an N of 30. We need to do a larger cohort to really validate that, but they're very rare, at least with the assays. Interestingly, we've looked for disseminated tumor cells in these bone marrow aspirates, and we see actually signatures in about 40% of those samples. Clinically, that's interesting because we know that about 40% of these patients with high-risk prostate cancer undergoing prostatectomy develop recurrent disease within 2 years. So we're starting to explore some of those biologic questions of, are these true DTCs, or disseminated tumor cells in that bone marrow niche? And are they ones that may lead to disease resistance or disease recurrence? So it's a great question. Specificity is a huge issue, especially as we look at the many different technologies that are out there. How are they accounting for it? Please, Anthony. Yes, sir.
Thank you for the presentation. You made a good point regarding the value of retesting with the longitudinal progression of tumor cells. But I want to go back to the early study you cited with lung cancer, when you said the original biopsy in 30 plus patients was adenocarcinoma, came back clear, small cell, and then again adenocarcinoma. Did the paper talk about why is that happening? Was that mixed tumors with sampling, or?
It is a perfect question. And it really said that with that limited biopsy, we didn't understand the disease at baseline. There's different discussions in terms of, are these transitions, is the therapy leading to some phenotypic transition? I think more likely what was happening were that there were two different populations of cells, and in some ways that adenocarcinoma in the microenvironment was able to, essentially when we look at resource utilization, was more successful in that microenvironment than the small cell lung cancer. Until you kill off all those adenocarcinoma cells, and that's when that small cell lung cancer has the resources it needs to grow and proliferate. So the biopsies did not show a mixed histology, though that identification on the second biopsy suggested it was likely present. That study's generated a lot of debate in the field as we look at these different questions. And I think, again, it just tells me more about the importance of getting more cellular and molecular information from our patients than we currently get. Well, certainly than we got at the time. We're doing a lot better now. We need to do even more. Sir.
So this will be the last question, because I think there's another group that's coming into this room afterwards. So.
Well, please, sir.
Yeah, I was curious whether is there any information on how soon after the disease initiation can you start to see these CTCs?
In terms of newly diagnosed disease or after a new therapeutic?
Well, maybe
both.
When the disease starts,
yeah.
How long it takes after that?
Yeah, we don't have good data, and I think part of it is because we don't have clearly validated technologies. When we look at the cell search technology, that when that's applied in different disease contexts, both at the time of, for example, PSA recurrence, we very rarely find events at those stages of disease. It's certainly with patients who have higher burdens of metastatic disease, we get more cells, and that's when we know sort of the dynamic range of the assay that, yeah, this is a true event. As the technologies are refined, we're starting to ask more of these questions at the earlier context, but coming back to the prior question, specificity is really critical. You don't want to make a mistake and tell someone they have recurrent cancer when they don't, if it's a failure of your assay. So I think we're going to need a lot of technology improvement to more accurately identify those patients.
Well, I know I learned a lot, Josh. Thanks for a great talk.